Hello and welcome to the third video on adrenal pathology. Here we'll focus on adrenal cortical excess and specifically on Cushing syndrome, look at the causes, clinical features, assessment, and treatment and prognosis. So by definition, Cushing syndrome is a cluster of clinical signs and symptoms from chronic glucocorticoid excess, whatever the cause might be. And it can be ACTH dependent or independent. So ACTH independent, or dependent, would result in hyperplasia of the adrenals, especially the zona fasciculata and reticularis, and increased secretion of both cortisol and usually DHEA as well. And the most common reason for this would be a pituitary adenoma, and in that case we call it Cushing disease. So Cushing disease is a subset of the syndrome. About 80% of all cases of Cushing syndrome are from Cushing disease. Again, a higher male to female ratio, 5:1 in this case. And then age of diagnosis is variable, but usually between 20 and 40. And the secretion of ACTH can be random and episodic. It can cause spikes of cortisol hypersecretion, but generally it obliterates any circadian rhythm of the cortisol. And again, androgens like DHEA might be hypersecreted, leading to hyperandrogenism signs and symptoms like acne, hirsutism, and other signs of virilization. Much less commonly, but important to know, would be ectopic ACTH hypersecretion, and that would be part of what's called a paraneoplastic syndrome, and that's usually from a bronchial carcinoid or small cell lung cancer. That accounts for about half the cases. This is going to be more common in males, and then this is going to have fewer classical features of glucocorticoid excess, so it has a little bit different, not quite as severe symptoms as a classic Cushing's. And the prognosis, unfortunately, is pretty poor because this is associated with a primary tumor process, and that's what the patient usually dies from. So that's ACTH dependent. ACTH independent would be cortisol excess usually is going to suppress the ACTH. So here we're going to have low ACTH, and we're going to have an exogenous source or a tumor hypersecreting cortisol itself. So the most common cause, and the most common cause overall, would be here drug-induced. So that would be taking glucocorticoids of any sort, prednisone, dexamethasone, etc., and that would suppress ACTH but raise cortisol or raise cortisol effects. All of these semi-synthetic glucocorticoids act at the glucocorticoid receptor in the same way, so they mimic the effects of cortisol. Having a primary adrenal neoplasm, adenoma is going to be the most common. Much less common would be carcinoma. Both are more common in females. And then there's a condition called nodular adrenal hyperplasia, where we get basically nodules of overgrowing adrenal tissue and they're hypersecreting. I won't go into that. There's a lot of variants of that as well. So those are the two main forms of Cushing's. Now again, in a more functional sense, we can have physiologic hypercortisolism, again, pseudo-Cushing's, and we think this maybe involves more of a problem in the hypothalamus with increased CRH. So there's stressors, inflammation, etc., secondary factors that are causing an overactivation of the HPA axis. And we get elevated cortisol levels, but they're usually less than 3 times the upper limit, and we typically see a circadian fluctuation in the cortisol. And I already went over, there's different forms that have Cushing syndrome-like features in terms of all the signs and symptoms. We'll go over here in just a second, versus others that don't have the same features. But we generally, if we suspect this, we'll do testing for Cushing syndrome, rule that out first, and then if we decide that this is more physiologic, we're going to use lower levels in the therapeutic order, essentially, to address this. So I'm going to go over the signs and symptoms of Cushing syndrome. We can have, of course, in Cushing syndrome, elevated cortisol, but you can also have elevated androgens and aldosterone. But in general, obesity is very common, Cushing syndrome. The fat can collect below at the base of the neck, the back of the neck, and that's what we call the buffalo hump or moon facies. The face becomes very rounded, so these are very classic characterizations of Cushing syndrome. There's a lot of cardiometabolic effects, so hypertension is the most notable, usually with a diastolic over 100. Glucose intolerance and actual diabetes, type 2 diabetes. Hyperlipidemia, usually with high LDL, low HDL, and high triglycerides. Polyuria and kidney stones. Thinning of the skin and atrophy of the skin, because remember, excess cortisol prevents repair of the skin and regeneration of the skin. Hirsutism, that's usually going to be from the elevated androgens like DHEA. Purple striae in the abdomen, hips, and breasts. Acne, and then easy bruising. These would all be some skin manifestations of Cushing's syndrome. Musculoskeletal, osteopenia, osteoporosis, very common. Weakness as well. Immune cortisol is going to suppress long-term your immune responses, especially more Th1 responses, but shift you often more into Th2, more allergy type responses. And then you're going to see more frequent infections because of that, delayed skin healing, and so forth. High cortisol is going to suppress the gonadal function, so there'll be lots of menstrual disorders like amenorrhea, impotence and decreased libido, and infertility. But most notably would be the neuropsychiatric manifestations, and that's going to be a lot of emotional lability, anxiety, poor concentration, euphoria, manic behavior, depression, and psychosis. No hyperpigmentation of the skin like we see in primary Addison's, and the overall appearance looks almost exactly opposite the Addisonian, the classic Addisonian appearance. So how do we assess Cushing's syndrome? Well, first will be our history and physical exam findings. We're going to rule out other illnesses, whether or not they're taking exogenous glucocorticoids, chronic alcoholism, other psychiatric disorders. I'm going to rule out physiologic hypercortisolism. It's not always easy to do, but if we suspect that there's been chronic stress, pregnancy, again, severe obesity, all of this are going to give Cushing-like presentation, but we don't always need to work them up for a full Cushing's evaluation. So especially if their blood pressure is normal, that sort of thing, they don't have hyperglycemia, probably Cushing's is unlikely. Clinical findings alone, though, can't establish the diagnosis. We have to confirm with the testing below here. If the screening tests are positive, this is the case, you do want to refer to endocrinology. If the screening tests are negative, but we still have a high suspicion for Cushing's syndrome, still refer to endocrinology. So that's usually where we go kind of outside the typical realms of primary care. Who should be tested? Well, if we find patients who are young with pretty advanced osteoporosis and hypertension, we want to work them up for Cushing's. If they have multiple progressive features of Cushing's syndrome, like the facial plethora, proximal myopathy, the purple striae, especially that are more than 1 centimeter wide in red and purple, and easy bruising. In fact, it's interesting, I had a patient, her primary complaint, she was in her 20s, she had hypertension. Her primary complaint, though, was severe fatigue. But when we did a physical exam, we did an abdominal exam, she had massive purple striae on her lower abdomen. It turned out she had Cushing's. Presence of any sort of severe features like resistant hypertension, osteoporosis at any age, and then presence of adrenal incidentalomas. So if you do imaging of the abdomen on an MRI, you find an adrenal tumor, and especially if they're a Cushing-like presentation, we want to work those patients up as well. So our first screening tests, these have a low, we're going to perform the test if there's even a low index of suspicion. We're going to just perform the test one time. If we really suspect this patient has Cushing's, so we might want to report the test, perform the test 2 to 3 times. And we're going to need generally, ideally 2 of these tests. But if the index of suspicion is low, we might just start with 1. But doing a late night, 12 a.m. salivary cortisol, repeated at least twice. A 24-hour urine-free cortisol, again, ideally repeated twice. And we should see values over 3 times the upper range to confirm Cushing's syndrome. And then what's called a low-dose dexamethasone suppression test. And that's where the patient's given 1 milligram of dexamethasone at 11 p.m. We measure their cortisol at 8 a.m. If their serum cortisol is less than 5, then we can exclude Cushing's syndrome. The test is very sensitive. So you gave the dexamethasone. That should suppress the the pituitary to not secrete ACTH, and that should not raise the cortisol as a result. If the serum cortisol is over 5 and often over 10, then we can pretty much use that as an initial screening test for Cushing syndrome. There is a high dose test using 8 milligrams of dexamethasone, and that's going to help us differentiate Cushing disease from an ectopic ACTH or an adrenal tumor. So in Cushing disease, we're going to see with the high dose test a decrease in cortisol levels. So we're going to see more than a 50% suppression, versus we're going to see no suppression with the high dose test of an ectopic ACTH tumor or an adrenal tumor. All right, so that's the screening test. Next, we're usually going to do ACTH after we've have a suspicion of Cushing's. If it's low, then we suspect that this is likely an adrenal tumor or hyperplasia. The problem with the ACTH test, I should have mentioned, is that it's very sensitive to how you collect it. So you need to make sure that if you're doing that on your own, you follow the instructions very closely. It has to be collected in a plastic tube, placed on ice immediately, and processed quickly. So that's important to keep in mind. There is a CRH stimulation test. Again, I usually will send this on to Endocrinology to do. This is where you inject CRH, and we should see an increase of ACTH and cortisol. That might support our Cushing disease diagnosis. If there's no increase in ACTH cortisol ratio, that's a negative response, and that's either an ectopic ACTH or an adrenal tumor. And then finally, once we suspect this, we're going to do imaging, and that would be an adrenal MRI to look for adenomas. If we suspect a pituitary tumor, we're going to do a pituitary MRI. And if we suspect the ectopic source, a chest CT of the chest and the abdomen. So that's a little bit more intensive workup than the adrenal cortical insufficiency. And unlike the insufficiency, we're not going to usually have a crisis or a life-threatening event, but definitely the risk of cardiovascular disease and MI and stroke and all that are definitely elevated in Cushing syndrome. Okay, so once we've established that we're dealing with Cushing syndrome and not physiologic hypercortisolism, again, our first thing's going to be, if we haven't already, refer to endocrinology. We might need to refer to a neurosurgeon for Cushing disease to remove a pituitary adenoma. But basically with Cushing syndrome, we're going to start at level 4. We're going to suppress cortisol, and the treatment will depend on the cause of the Cushing's. For the pseudo-Cushing syndrome, the more HPA axis dysregulation, we're going to go with levels 1 and 2 on the therapeutic order. So let's review that. So with level 1, our main thing here is to do things like decrease sodium intake and improve hydration. Exercise should be used with caution. Again, partly that's because the blood pressure can be so high, and that could be an issue. Blood pressure always goes up with exercise. It can come down after, but during exercise it can increase. And so that might cause dangerous elevations there. Working with smoking and alcohol cessation or reduction is important there too. Level 2 therapy is again more for physiologic Cushing's, and that's going to be using more things like sedative adaptogens, ashwagandha, bacopa, holy basil, and I've listed a whole bunch more there for you. Some nutrients like different B vitamins, but especially vitamin D, calcium to prevent the bone problems, and then manganese and lithium would be trace minerals which potentially could decrease the HPA axis. Usually replacement therapy is not going to be indicated because we're dealing with an excess condition here. But level 4 therapies are what we're going to do to address the pathogenesis of Cushing disease or Cushing syndrome. I should put CS there. And so for Cushing, for iatrogenic, obviously, Cushing syndrome, we're going to taper glucocorticoids. For Cushing disease, microsurgery, and that might take up to 3 years to fully recover from that. That would be the transsphenoidal hypophysectomy, so going through the nasal cavity, through the sphenoid bone to the pituitary would be the approach for that. Patients will likely need hydrocortisone for a time to actually restabilize their adrenals. This procedure fails in up to 20% of cases, unfortunately, and then up to 20% recur within 10 years. Ketoconazole can be given 200 milligrams every 6 hours orally for patients who are not candidates for the surgery, but you need to monitor their liver enzymes for that. For ectopic ACTH syndrome, you have to remove the source, which can be very difficult if it's due to metastatic disease. But with severe hypokalemia, we might need to use potassium replacement with spironolactone. And then different drugs, as I've mentioned before, that block the steroid hormone synthesis, like ketoconazole and metirapone. And then bilateral adrenalectomy might be required within subsequent replacement therapy. Prognosis, though, for this is very poor because of the underlying primary problem, which is usually metastatic disease, and all the complications we're going to get from that severely elevated cortisol. For an adrenal tumor or carcinoma, for adrenal adenoma, usually this can be removed laparoscopically. The prognosis is excellent, but again, patients might need temporary glucocorticoid replacement. For an adrenal carcinoma, very rare, but these tumors have usually metastasized by the time of diagnosis, so surgical cures are very rare with this. And here is where adrenolitics agents like mitotane are given to suppress adrenal steroid secretion, so that that tissue now is overgrowing, secreting all this cortisol. The prognosis here is typically very poor. And then you'll often see with Cushing disease or Cushing syndrome, patients are given bisphosphonates to protect the bone. So again, most of this is recognizing whether or not a patient has Cushing's and if they need referral, and then you could support them on the level 1, level 2 therapies, but really we're going to need the help of a specialist on this case. All right, so that is a summary of adrenal cortical excess conditions.